Teacher, foreign faculties, and learned audience. Very good evening. The brief history of the patient is 55 years old, man, non-normotensive, non-diabetic, smoker, and presented as a case of anterior wall ST elevated myocardial infarction 1 month ago. Now it comes with occasional chest pain, and echocardiogram shows the left ventricular ejection fraction is 52%. And coronary angiogram shows that his right coronary artery had significant lesion in the proximal and the mid segment, and the left coronary artery shows that his left main is normal, and LCX is dominant and free of disease, and LED have that is significant lesion in the that is early distal part and also the mid part. And we plan for the PCI to RCA and the LED. First, we plan for the PCI to the RCA and drug-eluting stent, that is 3 into 35 millimeter deployed in the RCA at 12 ATM, and subsequently we do the post dilatation with the NC balloon, and there is a final excellent result of the RCA. And next we do the PCI to the LED, and we first deployed stent in the early distal part with 2.75 into 30 millimeter stent, and next another stent in the mid and proximal part with 3 into 35 millimeter stent. Both are deployed at 12 ATM pressure. And we do the force dilatation with 3.5 into 12 millimeter NC balloon at 18 ATM. And there is a bolt from the blue is subsequently after force dilatation, free contrast extravasation into the pericardium from the early distal part of the LED. And based on the coronary angiogram, that is Ellis classification of coronary perforation is the 3 types, and we know these 3 types of this perforation. And there is a risk of component is if there is a type 3, it is 63%, if type 2, 13%, if type 1 is 8%. And one of the study shows the treatment plan and the type of perforation, if that is Ellis type 1, very conservatively manage this patient. Sometimes may require the prolonged balloon inflation, like 27%. If it is a Ellis type 2, most of the patient, that is, it needed the prolonged balloon inflation as well as pericardiosynthesis, and 7% cases require the cover stent implantation. If it is type 3, there is a 50% patient are treated with prolonged balloon inflation, and 43% are with cover stent, and 18% needed pericardiosynthesis, and 7% need emergency surgery, and 18% die. So in my case, it is a Ellis type 3 perforation and 63% risk of cardiac tamponade and 18% risk of death. And why perforation in the stented area of the LED? Is it due to the aggressive force dilatation with oversized NC balloon, that is 2.75 into 30 millimeter stent in the early distal LED, but NC balloon is 3.5 into 12. What we do now, that is, in conventionally we do the hemodynamic monitoring and echo to see the tamponade, intermediate, that is complete occlusion by the balloon, and expandable polytetrafluoroethylene cover stent may be used. On this way, we first inflate 3 into 12 millimeter NC balloon as a patient of intermediate complete occlusion several times, but fail to seal the perforation. Echocardiogram shows the mild pericardial effusion, that is 8 to 10 millimeter. And what next to do? We have the 2 options. One is the cover stent, but it has the high chance of restenosis and the thrombosis. And another one is surgery, it has the high morbidity and mortality. We consult with the surgical colleague and arrange the PTFE covered stent. And then we plan for the covered stent deployment in the coronary artery perforation site. And first 2.8 into 19 millimeter graftmaster stent are deployed, but free contrast excavation into the pericardium. So we inflate the another graftmaster that is 2.8 into 26. It's larger than the previous one, and it was almost seal the perforation. Why need the second cover stent? There is some technical issues there. The length of PTFE foil is shorter than the reported start length. After expansion of the stent, the PTFE foil may be up to 1.6 millimeters shorter from each end of the stent graft. The cover length of the stented area may be up to 3.2 millimeters shorter than the stent length. This information must be considered while choosing an appropriately sized cover stent. And final view is it was almost seal the perforation after second cover stent, and echocardiogram shows not increase the pericardial effusion, it is mild, but patient is hypotensive, need iron support, and hopefully patient is discharged at home after 5 days. My take home message is use of what size balloon, that is balloon to artery ratio is more than 1.2, and the higher inflation pressure during the PCI causes the coronary perforation. First objective is to stop the bleeding by the inflate a balloon at the site of bleeding. The most widely used device is expandable polytetrafluoroethylene covered stent may need to isolate the point of hemorrhage from the circulation. Thank you.